Welcome, everybody. It is National Cancer Survivors Day, and we are here to talk about the intersection of cancer survivorship and breast density. I am Leslie Ferris-Yerger, CEO and founder of My Density Matters, and I have three wonderful guests today. I could never do them justice, so I'm going to let them introduce themselves. But first, our sort of partner in this presentation, Laura Carfang, CEO and founder of survivingbreastcancer.org. Introduce yourself, Laura.
Thank you so much, Leslie. Thank you for having me on this very important day. Such a pleasure, because this is such an important topic as someone who was diagnosed with breast cancer at the age of 34. When we know that typically most people do not get screenings until at a minimum the age of 40, sometimes much later, which I know we're going to dig into later today. And so to be someone who is quote unquote young and diagnosed with breast cancer, I think knowing not just your family history, but your breast density is a really critical part of that educational journey. And since my own diagnosis, I've set out to start a 501c3 organization, survivingbreastcancer.org. So thank you for partnering with us. And we provide education, community, and support resources on the continuum of breast cancer, from prevention and education all the way through early stage, late stage, and end of life planning.
Fantastic. And we can find you at survivingbreastcancer.org, right?
Correct.
And social media.
Exactly.
Terrific. Everybody check that out. Dr. Monique Gary, please introduce yourself. Thank you for joining us.
Well, I am just delighted to be here and to see all of your faces again, and it's a joy. My name is Monique Gary. I'm a breast surgical oncologist, a breast cancer surgeon in Pennsylvania at Grandview Health in Sellersville. I am also the director of the cancer program here, and we're part of the Penn Cancer Network. And this topic is such an important one because, you know, we hear a lot about breast density, we talk a lot about it, but what does it mean for the survivor, for the thriver, and for really for everybody who's watching? So I think there'll be something for everybody, and I'm just glad to hang out with some old friends and chat about it.
Thank you. Dr. Rosen.
Hi, everyone. Dr. Barry Rosen. I'm a breast surgical oncologist in suburban Chicago, and I'm also the medical director of our cancer prevention program. And it's really an honor to be asked to participate. The work, Leslie, Laura, the work that you're doing is inspirational. Cancer survivors in particular, it's humbling how much you pay forward and how much you care about seeing that others don't have to go through the experiences that you've had to go through. And you know, Monique and I are on the other side of the table, as it were. This is our profession, but partnering with you in activities such as these is just so beneficial. So thank you for inviting me.
And thank you for being here. Appreciate that comment. We were actually talking about that earlier, Laura and I, about, you know, why it is we do this. And I think it's just a calling. You know, I think I couldn't not do it. And I think Laura probably feels the same way. So here we are trying to pay it forward and share what we know and what you know with people who need to know it.
And Leslie, I have to turn the tables quickly so you can introduce yourself as the founder of My Density Matters and the important work that you're doing.
Thank you. We're on a mission to empower women to find out their breast density and learn their options and advocate for themselves. There's so many things in the breast cancer space that we could do, right? And you do a lot of them, Laura. Other people do wonderful work, but we try to stay in that lane. And so we try to do that in every way we can. And here we are talking about survivors and breast density. So Laura, I want to ask you a question as head of a survivor organization. What do you think survivors want to know about breast density?
Yeah, thank you for the question, Leslie. And I think it can almost go in two different directions, right? Because I'm the head of an organization that focuses specifically with those who've been diagnosed with breast cancer. And it's almost like preaching to the choir a little bit. And then I know I want to unpack some questions that bubble up in my inbox and that I see on social media. And then there's the larger question of anyone who is diagnosed with cancer on Survivor Day, where we're celebrating our survivorship. for the men and women out there to actually know about their breast density. And so this is a really important topic that we need to bring to light, because I had never heard the word. I never heard the term. I never saw the hashtag. Why would I know? This did not enter into my vocabulary. And I think there's a lot of misnomers out there as well, that breast density is about what your breasts actually feel like, or the texture, etc., as well as the misnomer that men can also get breast cancer as well. Men do have breast, and they make up 1% of those who have been diagnosed with breast cancer. So I think it's really important for all of us, as we are celebrating our survivorship, to also know our risks in other areas, whether it's in my lane, in my realm of breast cancer, but then I also think very, very prominently about other women's cancers, endometriosis, ovarian, etc. And so I think this is a really important opportunity for us to just say, like, what is breast density? And how do we know about it? How do we find out about it? What are the risks for having dense breast? And like, what can we do to advocate once we find out whether or not we have dense tissue? So I think that is like a starting ground to kind of untangle this term that we hear all the time. I'd love to turn it over to Dr. Monique Gary to even ask, like, how do you describe dense tissue, and what do people need to know about it?
Okay, wow. I think it's a super important question, and it's one that you often don't find out until you read your mammogram report and you see at the bottom it says the sensitivity of mammography for heterogeneously dense or greater breast is diminished, and you're like, does that mean it didn't work? Like, what's going on here? But the way I explain breast density to a layperson, so in the medical term, it means the amount of glandular tissue, or the tissue that's making milk, that responds to hormones, the non-fatty tissue that's productive and formed by glands. But to the person who doesn't quite understand what that means, I'm a little old, and I talk in terms of things people understand, meaning console TVs. The static on a TV screen, right? The snow on a TV screen is a good way to think about breast density, because the density on a mammo shows up white, and it can show up sort of trabecular, spicular, or it can show up kind of staticky looking, snow globe, right? And so the radiologist is trying to see, one, patterns of that density to see if it's changed from year to year. They're trying to see calcifications, or maybe salt granules within the density. And they're trying to also see, are there some areas that are thicker or denser than others? And so it's really important, I think, for women to know that density, because there might be supplemental screening that they should get after that initial mammogram. And if you have breast cancer, it's really important to know your density, because it might change after things like radiation. And so, knowing that normal and being able to compare at maybe one side to the other, or what it used to feel like before radiation and after radiation, I think are important parts of helping a person to feel more secure about, checking for recurrence and things like that.
Wonderful.
Dr.
Thank
Rosen,
you.
I'm going to follow along with that and ask you, how do things like scar tissue and lumpectomies and radiation and all these things, some of which Dr. Gary talked about, how do they affect someone's density, and does that enter into the equation for surveillance?
Certainly. Thanks, Leslie. I think there's a couple of ways of looking at this. I think, first of all, we have to appreciate the fact that just about every woman who's seen a doctor in the United States has been told that they have dense breasts. And it's used very differently by primary care physicians and OB-GYNs when they're doing a breast exam, to say you have lumpy, bumpy breast tissue, or, oh, your breast tissue is very dense. And the density that we're talking about can only be determined by imaging. So many women have heard that term, but really don't understand what that means within the context of breast imaging. So in order to know your density, you have to have had a mammogram or perhaps an MRI. But that's the only way you're going to know your density. And the pertinence of density, as Monique elaborated on, is that it will mask a cancer. So it does limit the sensitivity of mammograms for identifying a cancer, and that's critical. The second part of that, as we all know, but I think is not appreciated in the community is it's an independent correlative risk for breast cancer. So a woman, we grade density A, B, C, D, A being very little dense breast tissue, D being a significant amount of dense breast tissue. And a woman with category D dense breast tissue has a 4 to 6-fold increased risk for breast cancer as compared to a woman with category A dense breast tissue. So it's a perfect storm of bad. It's masks cancers so that mammograms are less effective, and that same person with dense breast tissue is at higher risk for breast cancer. Density is complex. There's lots of factors that go into why a woman has dense breast tissue. Some hereditary, some are things that we can control, some things that change with age. And I'm not sure that I would put that in the same context. I'm landing the plane. I'm putting that in the context of your question about radiation and scar tissue. And I'm not going to put that in the same category as dense breast tissue, but I'm going to put that in the same category as things that make radiologists' lives more difficult. And that's where we're doing mammograms for different reasons. We're doing mammograms to screen for cancer. We're also doing mammograms after lumpectomies because women who've had breast conserving surgery are at an increased risk for cancer recurring in that breast, what we call a local recurrence. And by getting mammograms more frequently early on, we typically do mammograms every 6 months rather than yearly. The whole purpose is to help the radiologists appreciate that the changes that we inevitably caused by operating and by giving radiation therapy make it harder for them to determine if the cancer has come back. So they're cousins of one another, but they're really different. And I think when we're talking density, we're really talking about people who've either never had cancer, breast cancer, or people who've had breast cancer but are at risk for a second unrelated breast cancer.
You know, I want to jump in and say density itself gets a bad rep, right? Like it's the villain sometimes in the story. And I think that we have to change the way we look at that. It's a risk factor. It's a tool. It's something to know and be aware of. But the density is what it is, you know? And I think that we need to feel more empowered about that density and not feel either shamed because you have dense breasts or feel in some way anomalous because everybody has some degree of density it's in percentages, but also that density is just what it is.
Monique,
yeah.
I tell patients, well, first of all, that's really insulting. Your breasts aren't stupid. They're not dense. And what I like to tell women when I'm doing an ultrasound and you see that classic honeycomb pattern, which is what Monique and I see for every 20-year-old woman. And what I tell women is I don't say they're dense. I say, you have the breasts of a 20-year-old woman, which sounds so much nicer.
Sure does.
But equally obscures my ability to see that cancer on imaging. So
yeah.
I think that's really, if there's one take-home message from all of this, and I know that I'm preaching to the choir here, is mammograms are great, but mammograms are not enough for 40 to 50% of the United States population. It's just not enough. And it really, to me, is amazing when I see someone with category D dense breast tissue, and I'm the first person to have a conversation with them about supplemental imaging. So I think we've made, thanks to Laura and Leslie, I think through the two of you and others like you, I think the past 5 years have really significantly increased the knowledge base, but we've probably gone from 5% awareness to maybe 20% awareness at best. There's still a lot of people who have no idea.
Well, and I think part of that really great points, you know, Dr. Rosen and Dr. Gary is, yes, okay, now that we have the information and we know what density is, how do we advocate for ourselves? And a lot of us too, especially in rural areas or going to different centers that might not have latest technology in order for having more advanced screenings, how do we feel empowered to have those conversations with our doctors and when we go in for our mammograms? And it's a challenge. And so I think part of this education is, one, knowing if you have dense tissue, and then two, being able to ask, is there an opportunity for an ultrasound? Is there an opportunity for an MRI? Or maybe if not, maybe it's just an option of getting screened every 6 months versus every year. I would love to hear your feedback on, the proactive steps that patients can take.
Sure. I'll go first. I think that opening up the conversation for talking about density opens the door for conversations about a lot of other things, like knowing your other risk factors too. And so I love nothing more than when a woman brings that letter in and they say, okay, so help me understand what this means, or can you translate this for me? And it's in a way that just feels safe, and it feels like knowledge and empowerment, and it doesn't have to feel quite so scary. But then it gives us a chance to say to that patient, okay, let's go over some of those other risk factors. We've talked about density. Let's make sure we've gone over that family history. Let's make sure we talk about, your first menstrual cycle and menopause and all the other sort of things that factor into where you are in that conversation of risk. And sometimes all those things might not come up if a woman doesn't bring up the subject of density being a risk factor. So that's the first question. Can you explain this to me? Or what's my density? I heard about this. I read something. And then the second part of that is, so what should I do for that? Is there anything I should do differently? And those two questions, I think, can really empower someone, and you can walk out of that office feeling like you have a plan that's more specific to your level of density and your other risk factors.
Great point. Yeah, it's really so much more beyond knowing your density. It's really knowing your risk. And it's ludicrous. Why do we try to get a one-size-fits-all strategy for cancer screening? It makes absolutely no sense. The average size shirt is a size large. Why don't we just buy size large for everyone? Because it'll fit everyone the same. That's what we're trying to do with mammograms. And the reality is that we have so much data that allows us to segregate people by their risk. Breast cancer is unique. There's not a lot of cancers that have risk calculators. There's very few. So we have the ability to segregate our patients based upon risk, maybe intaking 3 to 5 minutes of information. Taking that information, what we should be able to do is we should be able to say, some people, as the USPSTF is recommending, some people can get their mammograms every 2 years and they'll be fine. But others won't be fine by getting mammograms every 2 years. And other patients need supplemental imaging. Why can't we have a plan that takes people's risks and modifies their screening based upon that risk? That's what we really are shooting for.
That's very interesting. So I have always sort of assumed, and this could not be 100% correct, that anybody who's a cancer survivor, particularly a breast cancer survivor, is automatically at high risk. You're automatically at high risk, but there are also other risk factors too. So is that true?
Yeah, yes. If
Okay.
you've had breast cancer once, it does put you in a higher risk group for another breast cancer. Even with the double mastectomy, although following a double mastectomy, thankfully, the risk of a second unrelated breast cancer is exceedingly low. But if you've had breast cancer and you've opted for breast conservation, you have a higher risk for a second unrelated breast cancer in your lifetime than the average person. And again, there's other risks to that. Let's just assume Monique and I work full-time on getting genetic testing for all of our breast cancer patients. So let's assume that most of our survivors, even though it's not true, but let's assume that at least some of our survivors have had genetic testing. And because that's going to substantially increase your risk of a second unrelated breast cancer if you happen to have a hereditary predisposition to breast cancer. But most of our patients don't, right? 5 to 10% of our breast cancer survivors have a mutation, most don't. So yes, we have to be more vigilant with our survivors about developing a second unrelated breast cancer. We actually have to be vigilant about them developing secondary cancers other than breast cancer.
I was just going to say that, Barry. Yeah.
Yeah. So our category, I mentioned that I direct our cancer prevention program. And our cancer prevention program consists of two populations of patients, previvors, survivors. So yes, if you've had cancer, we need to be more vigilant. But we have to also balance that with other cancer risks. So it's much more than just breast cancer, and it's much more than just density. We're looking at a multitude of risks. We take all of those variables and we put it into a care plan that's unique to you. Call it a personalized care plan, call it a precision plan. But every survivor, every breast cancer survivor needs a precision plan. And thankfully, most of our breast cancer surgeons are also doing surveillance. So hopefully you're seeing someone once a year who's helping you with that plan. And that's really where we can fine tune things. The harder part is the people who have no history of breast cancer, and they're just going by what the guidelines are, or what their primary care doctor tells them, or their OB. And it's so much better to hear that the USPSTF is going to recommend starting mammograms at 40 rather than 50, but it's still nowhere near far enough.
I'll piggyback on that and say a couple things. One, when a person gets genetic testing, many times you'll hear patients say, "Oh, I'm negative for the BRCA gene." But there are other genes. So we do a lot of panel testing, and we help to, as Barry said, come up with that personalized plan, not just for your breast cancer risk, not just for risk of recurrence, but for surveillance for other things. When I see a patient, I go down the checklist. Where are we with routine preventive health maintenance? Where are we with colonoscopy? Have we seen a dermatologist? We're checking for melanomas. Are we, because women can have, and anyone who has a primary cancer can have a risk for a secondary cancer, right? And so it's really important, I think, to know what that risk is, not just for breast, but for other cancers, and use that to feel empowered, because after a diagnosis, sometimes you kind of feel like, well, now what? I'm waiting for the other shoe to drop, right? But there's other things to focus on and other ways to address the risk overall, and to focus on overall health and wellness, that I think we really want to spend time and energy and lean into that, so that a person can feel, really empowered. And I think that's what I'll say about that. But really, the preventive task force, everybody's applauding, and I think they should have never moved it to 50, candidly. And I think we all agree, as the societies and the medical consensus, organizations, that come up with guidelines and recommendations, that 40 is where we would like to begin, especially for women at average risk. If you're not at average risk, you're 10 years younger than the youngest person. If you have risk factors, you might get a mammo at 30, you might get an MRI at 25. And so you hear those recommendations, and you really got to understand what that word average risk means. And if you don't know whether you're average risk, you got to go to a high risk program like Barry's or mine. You got to see somebody who can tell you where you are on that risk spectrum. And if you've had breast cancer, well, what is my risk for a secondary cancer, for another breast cancer? Does it change over time? And what's my plan look like now that I know I'm at higher risk? And those are all the questions that women should feel, armed to ask their doctors.
Dr. Gary, you bring up so many great points. And one thing I want to highlight too is, with the screenings, it's so important to know your family history. And so many of us actually don't. And I'll say right here, as part of this celebratory day of survivorship, I'm a white woman who did not know my family history. Everyone was like, oh, they're sick or they'll be fine. Everything was like kind of hush hush in my family until I was diagnosed with breast cancer, and things came out of the woodwork. And it was like, I wish that had I known Aunt so-and-so or Uncle so-and-so or so X, Y, and Z had these ailments, I could have brought that up to my primary care. And so I just really want to stress and underline your point that we only are as good as the information that we have. We can only be preventative and be proactive with, risk screenings and all of these things that you guys are mentioning, if we know and have the information and the data to support. So I encourage people, to ask the uncomfortable questions about family history and not to be ashamed by it. It's empowering, as you mentioned.
Laura, if I can elaborate on a question that you had asked earlier, that I think is important to emphasize. What is a woman to do to advocate on their behalf? And the reality is that if they're having a mammogram, they must know their density, A, B, C, D at the very least, right? So we need to empower our patients to know their density. And if a woman feels that they're at elevated risk for breast cancer, and the doctor who ordered that mammogram is reluctant or refuses to order supplemental imaging if their breast tissue is dense, then I would advocate that every hospital in the United States provides breast cancer surgical treatment. They have breast cancer surgeons. Find a breast cancer surgeon in your community. See your breast cancer surgeon if you perceive yourself to be at elevated risk. That's the best thing to do if your primary care doctor is reluctant or hesitant to order that test.
That's a great piece of advice, because that does happen a lot. Anecdotally, I can say, with just all the women that I wind up talking to all the time, is that they, we do all this work about empowering women to find out their breast density and learn their options and advocate for themselves. And then, boom, they go do that and they hit a wall. It's frustrating for all of us.
And I'll be honest with you, we need to do a better job educating physicians.
Yeah.
It's not just the public. It's not just the public. And on Wednesday, I'm invited to my hospital's OB-GYN department to talk about this, because you have to keep talking about this, because it's so confusing, because there's no one guideline. There's no, it's the wild, wild west out there. So yeah, you
who's
really
on first, right, Barry? It is, yeah.
Yeah. So you really have to hammer it home, and you really have to work. The fun part of being a breast surgical oncologist is that we get to work in a team. And I think my most important tool is not in the operating room. My most important tool is communication. And not just communicating to patients, but communicating to our colleagues and working as a team. That's really just as important as talking to patients, because we don't meet the people who are at risk for breast cancer. Unfortunately, most of the people we meet have breast cancer. It's too late.
You're right.
It's bittersweet. It's terrible when we do genetic testing and we find a mutation in someone, and the first thing that goes through our minds is always, had this person been tested 2 years ago, 5 years ago, this cancer could have been prevented. I mean, that's powerful. So, we have to move everything upstream. We have to move it, if not to the primary care doctors, then direct to the public. And that's exactly what I know I'm preaching to the choir. That's what the two of you are doing so well. Yeah. Keep doing it. Do it more often. and push for what we all want, which are federal laws that dictate what needs to be done, so that it's not on a state by state basis. Yeah, that's where the change is made.
We have to bring pressure to bear, right? Because these guidelines are saying, U.S. Preventive Services Task Force are saying, well, we don't think there's sufficient evidence to recommend supplemental imaging, right? They're saying that the proof's not there for them, but the FDA said the proof is there for them. I'm in Pennsylvania. They just passed legislation that said we not only believe it, but we're going to cover the cost of it, right? So that women don't have additional cost to absorb for that supplemental imaging. So now a woman's like, well, what am I supposed to do? The task force says this, my doctor says this, the public opinion says this, and my insurance company says, whatever. And so they don't know. And so I think it's important for advocacy groups to really continue to put pressure on all of the folks who make these recommendations to do the research, do the math, right? Figure it out and come to consensus, because where there's confusion, you're going to have missed screenings, you're going to have missed opportunities. And, it's a travesty in this day and age when so many of these things can be detected early, and so much of this is preventable.
Yeah. We do have a quick and easy way for any woman to hop on and write to her congressperson to urge them to vote or co-sponsor the Find It Early Act, which will get at a federal level a lot of the things covered that need to be covered. So we'll post that link when we're live. so everybody can have the chance to write to their congressperson. And as you say, advocate, keep
Yeah.
pushing for these things. And, you know,
Yes.
it might be annoying to, you know, the congressperson, but we got to keep doing it. All right. Okay, so we've talked about so many things today. Such wonderful, wonderful information. Can we bring it back to, since it's National Cancer Survivors Day, if for all the survivors out there, what should they do? What are your parting words to survivors out there for them to do now that they have learned what we've all said? We'll sum it up.
All right, can I start off there? And what I would want to emphasize more than anything else is just how powerful of a message it is when it comes from you rather than from me. And I know that many of my patients do this, but you can't underestimate the importance of talking about mammograms, because the reality is that only 60% of breast cancers in the United States are diagnosed by screening. 40% are diagnosed after symptoms develop. And if you look at our practices, we have two groups of patients: those whose cancers were diagnosed by screening and those who weren't. And there's quite a difference. So it's as simple as just get a mammogram. So many people aren't doing that. And as a survivor, people listen to you. And so please share that message as often as you can. And the second message, of course, knowing your density and advocating for supplemental imaging if you have dense breast tissue. So to me, those are the most important messages. And please make no assumptions that because you don't have a family history of breast cancer, that you're not at risk for breast cancer.
Mhm.
Because breast cancer is an environmental disease most of the time. Breast cancer wasn't anywhere near as common 100 years ago as it is now. And regrettably, they predict that breast cancer rates will continue to rise over the next 20 years.
Mhm.
It's the air we breathe, it's the food we eat, it's a byproduct of our environment very, very often. And so please don't assume that if you don't have a family history that you don't need a mammogram, please. All right, I'll stop, Monique.
Okay,
I don't
thank
want
you.
I want to turn it over to you. Sorry.
No, that was
Yeah.
amazing and so,
Yeah.
so true, you know, because one, we know that the rates of screening are low. You're absolutely right, Barry. You know, when you look at the claims data from insurance companies, 55% of women might be getting them. And even on the questionnaires, they're saying they're getting them, but they don't detect everything. Right. And so my three things, I guess, are, you know, take note, take charge, and take action. Right. So take note of that family history, take note of that breast density, take note of your normal, right, and take charge, meaning let's put a plan in place to get these things done and to feel more empowered about it. And then take action is, well, one, you got to do something about it. So you've got to get that screening, you have to advocate for yourself, you have to ask the doctor those questions. And on the advocacy side of things, take action, meaning talk to those legislators when there are opportunities for advocacy and for, you know, when you go to the Hill and that sort of thing. Really lean into these things. When are we going to know what kind of data are we collecting? Who's doing the research? Is there funding for that? And, you know, how can we all be on the same page, you know, and really take some action to help make things more transparent and also more equitable, right? Because there
Yes.
might be some things in certain populations that might be even higher risk. Black women, for example, have, you know, up to 30% greater breast density than white women even. So maybe they should be getting screening sooner. We don't know. The data's not there. And so we can increase the funding, increase the awareness, keep asking the questions, and it's such amazing work because you're really showing people how to do it. And everybody can take a lesson from this program today and from the work that your organizations are doing.
Thank you. Great summary. Laura?
Yeah, I'll add is just kind of piggyback what I was mentioning earlier about like family history, right? So my personal example, my dad is one of 4 boys. I have so many uncles. I don't have a lot of aunts on that side of the family. How would we know if there is breast cancer, right? If they're like, it's not genetic, it's not in the family. Well, there were no females on that side of the family. Not to say that men can't get breast cancer, but it was a low risk situation. And I still was able to, unfortunately, develop this disease. I would also say for all of those who are being, celebrating today in survivorship, regardless of what cancer you have, we know survivorship is challenging. It's lifelong, and they're what I call the whack-a-moles, right? Like there is always something that's going to bubble up and throw a monkey wrench in our plan. And so for me, I think not only is advocacy really important, I want to collect as many doctors and people on my team in my back pocket. So if that means getting my, primary care or my radiologist or my OBGYN or my GI doctor, like anyone who can like help me with my own screening, the better. And I know, sometimes I call it doctor fatigue, where I have so many doctor's appointments, I just don't want to like have to do it anymore. I know they're all here rooting for me, and it's because of that survivorship plan that is so important. And I encourage everyone to stay on that plan and ask and advocate and get as many doctors in your back pocket as you can, because we're all here to help.
Amazing.
If,
Thank you.
if I can add one thing, maybe to focus on the positive. I've been doing this for 31 years. And the one thing that I have seen, and I know will continue to happen, is things keep getting better. Okay. I practiced when there wasn't such a thing as non-surgical biopsy. I practiced when there wasn't such a thing as a BI-RADS code, where radiologists read things and doctors chose to do what they did. We've made progress every decade, and we're going to continue to make more progress. We all know about AI. Okay, AI is an incredibly powerful tool for imaging, and it can actually be used to measure risk. There is an AI tool right now that's being studied where all you have to do is look at a woman's mammogram, and just by pattern recognition, you can come up with a 2-year and 5-year risk of cancer. So that I envision a day where a woman gets a mammogram and they say, well, based upon your imaging, come back in 6 months because of your risk, or come back in 3 years. So that day is here. There's also circulating tumor DNA for cancer screening. We're already there with some cancers. It needs to be perfected, but I really do believe before I retire, there will be a liquid biopsy, a blood test for breast cancer screening. So there's a lot of things on the horizon. We already know, we talked about screening ultrasound. There's MRI, there's molecular breast imaging, there's contrast enhanced mammography. There's all these other ways of getting past dense breast tissue.
Right.
So, the future is bright. We have a lot of tools that we never had. We just need to focus more on prevention, which is a completely different conversation. But
Maybe we can have another conversation about that sometime.
We got to do it.
That would be
Yes.
great.
A good follow-up for sure.
Yeah.
Absolutely. Well,
Yeah,
happy
yeah.
Survivors
Thank you
Day.
for talking about the upside of all of this,
Mhm.
because we can get down, mammograms and lower sensitivity because of density and blah blah blah. It's all bad, right? But there are so many good things that are happening. And the liquid biopsy really excites me because I was diagnosed with lobular, and all these things we talked about with mammograms not being able to find it is particularly true of lobular. So exciting in that regard.
There are some new and
It's-
emerging technologies, though, that are really getting better at detecting that type of density too. Things like elastography.
Okay.
Whether it's so we're getting there. I think Barry really hit the head on the nail with that.
Awesome.
I think one other thing that this is Survivors Day. We're talking to survivors and breast cancer survivors. There is a liquid biopsy for surveillance
Mhm.
that has been approved by Medicare. And the issue is that we actually have a good test. We have many good tests to do surveillance in the breast. What do we do in the body?
Right.
How do we know if the cancer has come back or not? And regrettably, the standard of care has always been medical oncologists just simply asking how you're feeling. Because
Mhm.
tests like CAT scans and bone scans and PET scans, we haven't been doing them because we won't find it any sooner than just symptom-based surveillance. But now there's circulating tumor DNA testing. There's one company that has it on the market, and at least one more that'll be on the market later this year. Ask your medical oncologist or breast cancer surgeon about systemic surveillance with circulating tumor DNA testing. It's a great option.
Mhm.
Very good. Thank you for that. Exciting stuff.
I like taking
Okay,
notes.
it's time to wrap it up. Parting words, anybody? Or did we do that already? We did that already. Awesome. Dr. Gary, repeat those 3 things that you said. It was take
Take note. Take note, take charge, take action,
take
and
action.
take hope. I'm adding a 4th one for Barry.
I love
Right?
it.
There it is. Number 4
Love
is,
it.
is take hope, you know, and that's the
Wonderful.
takeaway for today for our survivors. Take hope, because so much of the cancer experience can feel hopeless, you know, but there is so
Absolutely.
much hope. So I love it, and I'm just really, again, grateful to be here. And folks can follow me on social media on all outlets. I'm Dr. Monique Gary on all social media, and you know, doing shows Wednesday night on blackdoctor.org. The Doctor is In. You can catch me doing some lives occasionally, and just hanging out with the cool kids here with all of you. So
We will post links for everybody's social and all that, so everybody can have access to you wonderful people. Happy National Cancer Survivors Day, everybody, and thank you so much for joining us.